Okay, good morning. I think we'll go ahead and get started with grand rounds today. Just one quick announcement, just to remind the group. We have our inaugural Houston Heart Failure Summit, February 12th, next Friday, and hopefully you received email announcements, and we're excited about the agenda and guest speakers, really covering the full breadth of heart failure in preparation for Heart Failure Awareness Week the following week. So this morning we're delighted to have Dr. Brian Olshansky present to us the topic as listed. He's a well-recognized, internationally recognized, board-certified cardiac electrophysiologist, professor emeritus at the University of Iowa Hospitals. Did his medical school training at the University of Arizona, followed by internal medicine residency at Bellevue, NYU hospitals, and fellowship at the University of Iowa, and had been on staff at Case Western, Loyola, and has spent the majority of his time at the University of Iowa, where he's directed the EP lab in addition to training programs. His clinical expertise and research expertise in cardiac arrhythmias, device implantation, and ablation is well recognized. He has over 200 peer-reviewed manuscripts in this area, has served as section lead for the NIH in the context of trial oversight, executive committee review, data safety monitoring boards. He served as national PI of an important device-related trial, and is a editor of several highly regarded peer-review journals. So it's a real privilege for us to have such an internationally recognized expert speak to us today on the future of healthcare, placebo, and the doctor-patient relationship. Dr. Olshansky.
Thank you very much. Good morning. I'm going to talk about a topic that I think is, to me, the most fascinating of topics in medicine. It might be a little bit of an unusual grand rounds, something you might not have heard before. We'll try to get through as much as possible. This topic, you might think, how could you spend even more than 5 minutes talking about it? Well, you could probably spend the entire day, many days, years talking about this topic, since it's probably the core of what I think medicine is all about. And I titled this, The Future of Healthcare, Placebo and the Doctor-Patient Relationship. I shouldn't just call it the doctor-patient relationship. I should say the nurse-patient relationship, the nurse-practitioner-patient relationship. But one thing I will not say, and I might mention this in the talk, is that we are not healthcare providers. Our name didn't change. We are not providers for some system. We are doctors. We are nurses. We have professions, and we are here because we take care of patients. And part of that issue relates to the issue of placebo. And what I'd like to do today is tie the concept of placebo to what we do when we care for patients. That makes it almost impossible for us to be replaced by any other kind of system. In other words, I don't think there'll ever be a time when we won't have doctors or nurses where someone could plug in on a computer their symptoms and then spit out a pill, and all of a sudden they're going to be magically cured by the science that may be purported to happen when that pill creates a physiological response in that particular individual. I have some disclosures. I guess the only one that really is important, because it does bias me to some extent, is I was a placebo expert on a Federal Trade Commission case. And I'll talk a little about that later. So the question is it really all about the science? I mean, most of what we talk about at Grand Rounds is science. And I am going to talk about science today, but I'm going to talk about it in a different way. And I was going to have a questionnaire, but it turned out it was a little bit complicated to get that done, and the time that it would have taken to allow it to happen here would have been extensive. And so I do have a questionnaire that we used at the University of Iowa, and so these are responses that we got from the University of Iowa at a talk similar to this in the past. So first question that I had asked was about medical therapies, and I want to point out some differences and interesting differences between residents, fellows, and faculty. And the question was, most medical therapies I use in my practice are based on sound scientific evidence. Residents thought that most of that was true. Fellows thought it was a little bit less true. And faculty thought it was a little bit less true. So there's something else we do. We do use the science. But when it comes to the patient that's sitting in front of us, we have to make decisions and choices that are based often on gray zones that aren't necessarily based on a yes or no answer that you can find from a specific study. And I think this is one thing that all of the regulatory bodies don't understand. They think it should be very simple, and that it's a line you cannot cross. One way is correct and one way is incorrect. Well, as we know in medicine, when we take care of patients with multiple problems and complexities and families and emotions, that it's impossible to care for those patients without considering the other issues besides the scientific data. So the first principle, has been stated many years ago by Maimonides, should be doing nothing before improving the patient's state of mind. And as it's been said from the Buddhist literature, the nature of mind is the nature of everything. I mean, basically, what you perceive is what becomes the reality. If you don't perceive anything, there is nothing. And therefore, you have to start from some point. And that is one point that's reasonable to start from. So what's a placebo? Well, a placebo is actually very complicated. And this is also not understood. But the placebo effect is a little bit different than the placebo. But a placebo means that I will please. It's a simulated intervention of some sort that will provide potentially benefit. A nocebo, on the other hand, is a similar kind of simulated intervention that can cause harm. And up until recently, this was the crux of medicine. If you think about randomized, double-blind, placebo-controlled trials, this is something reasonably in the modern era. But medicine has been existing for thousands of years. And how did that happen if we didn't have a real therapy that worked? We used all kinds of stuff. We used herbs, we used, magical potions, we drilled holes in people's heads. And if you remember, actually, George Washington, our first president, died because of pharyngitis. He died because he was bled to death, because people thought that, phlebotomy actually could cure his pharyngitis. And it was the last unit of blood that did him in. So we used all kinds of nasty therapies, leeches, and some of those actually work. But basically, there was the point where the doctor was an important person in the community, because that was a wise person, a person that could offer advice and actually created much of what happened from the placebo benefit rather than the real science benefit. Early placebo effects. The Perkins tractors, Haygarth described, were metallic rods that were a little bit like using acupuncture. But he made imitation ones out of wood, and he found that they worked just as well. He said, prepare these false tractors to resemble true ones, but don't tell the patient about it. Benjamin Franklin also showed that some of the early therapies, like mesmerism, which was really big, magnetism to treat problems, was all a fake. Some of these things are good, some of these things are bad to learn about. But there are many things fake that we use in medicine, and actually the astonishing fact is they work. Sometimes. Some early placebo comments are, one should use a drug as often as possible. Trousseau said this, while it still has the power to work. And Hippocrates said, it's far more important to know what person the disease has than what disease the person has. So let's talk a little about some placebo effects. This is a study by Shapiro and Shapiro from 86th Street in New York back many years ago. And they took 6,000 psychiatric patients, and they gave them a sugar pill. And they said they wanted to know if this was going to make them feel better or not. And then they looked at their responses to psychiatric therapy, which was mainly talk therapy, which is placebo. They found that when they gave them this pill, 51% felt better, 12% felt worse, 37% had no response, and 57% had side effects to a sugar pill. But placebo predicted medication response, and none of 78 characteristics that defined a placebo responder could define a placebo responder. So this was a really powerful thing. Half of the people felt better from a sugar pill. And they then responded better to medication. This is what we see with placebo effects. But when it comes to pain, there was some work back in World War II, these kind of things we cannot do today with IRBs, where they looked at giving placebo versus morphine. And they showed that morphine actually reduces pain, not a big surprise. But they found that, and that was about 70% reduction in pain, but they found that 50% of the patients who received a placebo felt better. And this is for severe pain. So up to 35%, and perhaps a little bit more, depending on the situation, of people that have a response, at least in part, have a placebo response to what we give them. Now, I asked the question to the Iowa audience that, you know, a sham therapy, that is a placebo, some kind of sugar pill or something, can have an adverse effect. And most people said yes. And this is known, the nocebo effect. And here is a study of a double-blind placebo-controlled trial of volunteers. 28% had an adverse effect to placebo. And when queried, 71% had an adverse effect. So what does this mean? You know, you give a patient a pill, they look it up on the internet, and they find that they can have a side effect to this pill. All of a sudden, they develop that side effect. But they didn't even think about it until they came to your clinic, and then you asked them, well, did you develop shortness of breath on this medication? Oh, yeah, now that you mention it, doctor, yesterday I wasn't feeling so good. They all of a sudden develop more adverse effects to something. And this leads to dropouts in studies. So studies basically then are preloaded to show benefit to whatever they're getting, because all the people that develop nocebo get out of the study and perhaps won't even enroll in the study. So disability and death are possible from nocebo effects. And I think the nocebo effect is actually rather common in clinical practice. So here are some examples. In the Framingham study, women who thought they were more likely to die were 4 times more likely to die, even if they had the same comorbidities and the same issues when done in a multivariate analysis to all the other women that didn't think they were going to die. Asthmatics who breathe saline but were told that it was an irritant develop an asthmatic attack. I think a lot of drug side effects are nocebo effects. Cardiomyopathy, secondary to emotions, is a well-known effect. And even the idea of voodoo deaths have been described. And I don't know about the reality of this, but I suspect that it, in fact, is a real situation where someone expects that they're going to die, and they could very well do so. So when we think about albuterol, does it really work? Well, here's a study from the New England Journal a couple years ago where they compared albuterol to placebo to sham acupuncture to no interventional control. And in fact, if you look on the left side of the slide, the change in FEV1 is impressive with albuterol compared to placebo. That's not an issue. I mean, we know that there's a physiological effect from albuterol. But the issue is, did the patient feel any better? And I would think that that's probably an important issue. That is, there's symptom improvement. The patient is functionally better than they were before. And if you look on the right side of the slide, those who received placebo were functionally as good as those people who received albuterol. And those who received sham acupuncture felt just as well as if they received albuterol. So if there's an improvement with placebo and they feel just as well, is there really an advantage of giving albuterol? Because basically you're giving a drug that has potential adverse effects, and it doesn't necessarily any benefit except for unless you can show an outcome measure such as mortality or something else that leads to other problems, which was not shown in this study. So I think drug reactions are common. I think that inert substances do cause adverse effects, and it turns out that women experience this more than men. We'll talk a little about that, because I think there's a gender, racial, and actually a genetic predisposition to placebo and nocebo effects. And I think this problem actually occurs frequently. Now, here's some data from beta blocker side effects. This is basically a kind of an analysis of about 35,000 patients, 15 trials. And they looked at the beta blocker side effects. And in fact, yes, beta blockers can cause the risk of depression. Beta blockers can cause risk for fatigue and sexual dysfunction. But if you look at the numbers are not as great as they appear to be. So we preload patients when they come in to see us, and they are already expecting that they're going to get a side effect. They already think they're going to get fatigue. We already tell them that they might get fatigue. Then you ask them if they're going to get fatigue, and of course, yes, now they have fatigue. But in reality, did the drug cause that fatigue? Or was this something that was in their mind or pre-programmed in their mind that allowed them to think that they may get a side effect? And therefore, the drug gets stopped, and the benefit of the drug is no longer there for that particular patient. I talked about emotions in cardiomyopathy. This is a well-known effect, the so-called Tako-Tsubo Cardiomyopathy, which does occur more in women than men. And this has been fairly well mapped out. We're not going to talk about all the details of this, but it's a sympathetic activation which leads to cardiomyopathy, an acute cardiomyopathy that's reversible frequently. And it looks like an octopus pot, and that's why it's called Tako-Tsubo. It's a Japanese word for this kind of octopus pot. And it often occurs in situations, for example, where a woman may find that her husband just came into the emergency room with an acute stroke or just died, and then she may go into acute heart failure and develop this cardiomyopathy, which then can reverse itself. Totally due to emotions. This is not due to a physiological effect. So it shows the impact and the potency of emotions on outcomes when it comes to cardiovascular issues. So are placebos still used? Well, here is a question asked to internists and rheumatologists, and those 57% responded, so we don't know about the other 43%. But they did report, about half of them reported that they do use placebos, and they believed it's ethical. And here are some of the things that they used. But I will say that that's probably a very large underestimate of what really goes on. First of all, I just want to show you something that's total placebo.
Head on. Apply directly to the forehead. Head on. Apply directly to the forehead. Head on. Apply directly to the forehead. Head on is available without a prescription at retailers nationwide.
Now, you might have seen commercials like this. People buy this stuff. I mean, this sold millions and millions of dollars worth of this product that actually does nothing. I mean, it didn't even say it did anything, but people would buy it and think it did something, and they used it. So people actually will accept the idea of taking placebo, and who knows what else they're taking, but all kinds of supplements that can be potentially dangerous. And I have a question for you about this. This is a legal precedent, and it basically was this. I ask you a question. Is it okay to sell a product that cures pain in 80% of those who use it, and have no side effects, by the way, if the results are the same as placebo in a double-blinded controlled trial? In other words, can you give a placebo to a patient that has an 80% chance of being effective and totally safe? Is this reasonable to do? Would you do it? I think most people say yes. Well, this turns out to be, went through the Federal Trade Commission, and they said, this is not, you cannot do this. And so products that get approved through for the FDA have to show benefit over and above a placebo. But, in clinical practice, all the time, we do this. We do this frequently. Here is a response from University of Iowa. I use placebos in my practice. About 37% said yes. Actually, 31% said yes. But I think this is actually also an underestimate. Placebos are still used. Here's an example. This is from a New England Journal paper on the use of chiropractic therapy versus giving a booklet for severe back pain versus physical therapy. I don't know. I think they're all placebo. I don't know. I think chiropractic medicine maybe is more than placebo, but I'm not so sure that it's more than placebo. But do any of your patients, or did you ever go to see a chiropractor? I bet you did, or I bet you know some patients who did, and I bet you felt better about it too. And if you look, all people got better, the same. Didn't matter if you got a booklet, chiropractic therapy, or physical therapy. All got better. They got better because they thought they were going to get better. But it doesn't mean that there was anything physical that actually happened. And what about in cardiology? Do we use placebos? I don't know. Has anyone ever prescribed digoxin? Does it do anything more than a placebo? This is the DIG trial. This is the biggest trial of digoxin. This has been bantered about for years about what does DIG do. In fact, you can find meta-analyses that show that DIG kills people. I mean, if you believe those meta-analyses. But whatever you want to believe, and whatever is true, it turns out that digoxin, which is now becoming a very expensive drug because it hasn't necessarily been proven to be very effective, even though it's a really cheap drug, hasn't been shown to be any better than placebo. And yet we use this all the time. Why do we use it? Is it because of its presumed purported physiologic effects that may not make any difference? I don't know. But I will say this. Whatever the case may be, I would bet that somebody in the audience has taken a Z-Pak for a viral syndrome. Or, if you haven't, you've prescribed it to somebody. And I bet if anyone ever worked in an emergency room and has taken care of a child that came in with their mother at 3 o'clock in the morning, is screaming and has a virus, that you're probably going to send them home with an antibiotic. I would bet you. And there's no evidence that it makes any difference. In fact, it could probably kill that patient because we know that erythromycin, for example, can lead to torsade de pointe. It's a potentially dangerous drug. But over 3 billion prescriptions are written every year. It's up from what it used to be, often for ambiguous, self-limited, and non-specific complaints. We give things to people all the time. They come and they want something from us. So we give it to them. Is it proven? Do we have these double-blind, placebo-controlled trials that show that every single prescription we give to every patient actually works? No. Do we have any good evidence that Lasix actually works for congestive heart failure? Well, that's a whole different story. But, I mean, it probably does cause diuresis. There's no question about that. But what is the real evidence that makes a difference? And there is probably good evidence, and we're not going to talk necessarily about that, but there's a lot of placebo effects that we give to patients simply by giving them a prescription. Now, this is probably known better by drug companies than we know, but they won't give us this information because it's marketing. But we know, for example, blue pills are better as sedatives. We know that yellow pills are better as stimulants, and red pills are better for the heart. Branded is better than generic. So when you give an expensive medication, the patient is expecting to get a better response than if you give them a generic, a cheap drug that anyone could use, and you've been using it forever. They'd be safer, but it's not going to get the same benefit. Surgery is better than a pill. Larger capsules are stronger, injections are better, and the stronger the placebo, the better response. This is important when you think about clinical trials, as I'll show you in a minute, because you can't compare. One placebo is not the same as another placebo. Now, I'm mentioning this because a friend of mine who is very much involved with anticoagulation comes from South Africa, and his father was a family practitioner. He took care of many people that were Zulus. And the Zulus believe in this kind of witch doctor, but when he would see the patients, he would give them an injection in their muscle, I think just plain water. And he was considered a very good doctor because he gave them what they called it a stellic jorva, which means a very strong medicine. Because the more the pain that occurred, the more that this was a real medicine that was going to do them some good, and they felt a lot better. Now, there might be an actual neurophysiologic mechanism by this, the mu receptor activation in the brain because of pain, and this is part of the mechanism by which placebo may work. But nevertheless, they're looking for the placebo. They're looking for someone to do something, even though it's actually doing absolutely nothing. And this happens frequently in medicine. So the issue then becomes, is where does the doctor fit into all this? What does the doctor-patient relationship have to do with this? Does the doctor-patient relationship have a major impact on the outcome of patient's care? And this is where we fit in, and we're critical, and we'll always be critical when it comes to health care. And we should never be considered providers, because we are doctors from our profession, we are nurses because from our profession, because we care for patients, and that's something that cannot be replaced by anything. But what is that? What are we actually doing? What are we actually doing when we're giving a placebo? What are we actually doing talking to the patient when we aren't actually giving them any surgery or anything else? Well, this goes back quite a bit, quite a few years. And this was patients with nonspecific symptoms, and they had a positive consult or a non-positive consult. In other words, the doctor said, I know what's wrong with you, and I know what we're going to do. We're going to treat you with blah, blah, blah. And the other one would say, I don't know what this is. Maybe it's just your nerves, there's nothing actually wrong with you. So positive versus negative, and then they looked at outcomes. And what he found was that the doctor, basically by the approach of how they approached the patient, had a powerful effect on how the patient felt. So the doctor is a placebo. The doctor actually feeds right into this effect that occurs with a pill or a surgery. And the point is that a placebo isn't just a sugar pill. The placebo is this response that occurs in a patient due to an apparent beneficial therapeutic input, a positive beneficial therapeutic input that they're going to expect. Part of this is an expectation effect, and part of it is more than an expectation effect. So what about the doctor's role? Well, this is actually a very complicated thing, because in another study, it was a double-blind study for pain. One group was either given a narcotic antagonist, or a placebo, and the other group was given a narcotic antagonist or placebo. Now, only the doctor knew which group the patient was going to be in. And if the doctor knew that the patient was in group 2, they knew that patient would not get any benefit from that therapy. And so that the patient would then give clues that the patient could pick up on. Even though he didn't say or she didn't say anything, the patient actually knew this and therefore didn't get the same effect. So there is a role that is even a subconscious role. And it could be simply looking at a patient a certain way. It could be saying something you don't even realize that you said, something in a positive or a negative way. It's amazing how much power we have when a patient talks to us and they're scared when they come in to see us and they think they might have cancer, and you tell them everything's fine. That by itself, it has a huge beneficial effect. If it's true, if the patient believes you. If the patient thinks you're a liar or has no reason to believe you at all, that will have absolutely no effect, and that patient will go to doctor after doctor after doctor to find the person that patient actually believes. Now, there's another issue when it comes to placebos that's I think important. This goes back to Harold Sachs. He was the editor for Annals of Internal Medicine for many years, and he found many years ago that people with atypical chest pain, so this is a young woman who comes to see you. She's been in the emergency room a bunch of times. You know, you get an EKG, there's nothing. She has this terrible crushing chest pain. What are you going to do with her? Let's say even cath her. I mean, what, God forbid, 20-year-old. But whatever the case may be, you do you don't do that yet. Before you do that, this is what you have to do. So if you send the patient away and don't do anything, that patient will have more and more problems. So what he did was very simply, he randomized patients into two different groups to do tests, any test, treadmill test, echo test, imaging test, versus no test. And then he looked at disability and looked at outcome. And he found that those who received no test did much worse. This is a no-brainer, really. We all know this. So that's why we do it. Now, then you could say, well, you want to do a test that's safe, that's going to potentially pick up the problem, not harm the patient. And it does add to the cost of health care. But on the other hand, what adds more to the cost to society are people that are disabled and keep coming back with complaints. And they fill up the clinics, and they're not going to get any better. But if you do the test, 100%, you're fine. You don't have anything wrong with you. It's not your heart. Some of them might believe it, some might not. But you're going to be getting a tremendous benefit from doing that rather than just ignoring the problem, because that problem will not go away for that patient. Now, one thing that's been found is that pacemakers seem to work for neurocardiogenic syncope. Here's a study from the VPS-1 trial, positive tilt table tests. Small trial, but it was a multi-center randomized trial, highly significant, showing that pacemakers improve outcomes in neurocardiogenic syncope. Is there any problem with this study? Is there a reason that, is this news to everyone here that, is everyone now implanting pacemakers every day for patients with neurocardiogenic syncope? Are we doing it? No, we're not doing it. So what's the problem with this study? And I tell you that many people, including one of my old mentors, could never get the concept of this. And this is a critical concept. It's pacemaker versus no pacemaker. There's no placebo. You need to have a placebo. Well, what's the placebo? Can you give them a pill? Well, a pill is not a pacemaker. The patient knows that they're getting a pill. It's not the same as a pacemaker. You're going in there and you're opening up the skin and you're sticking something into a blood vessel and you're putting this potentially risky surgery and it's going to cost some money and it's going to supposedly make my heart beat better, so I shouldn't be passing out. So you have to do a placebo pacemaker. You have to put the pacemaker in, not tell the patient, and turn it off. That's the study you have to do. And you can say, it's unethical to do. Well, if it's unethical to do, can you imagine how many pacemakers you'd be putting in normal, healthy people all the time if we really thought that pacemakers made a difference? So that was done. That's the VPS-2 trial. And there was no difference. So the pacemaker was a total placebo. And in fact, almost every therapy that's been tested for neurocardiogenic syncope is a total placebo, or worse. It has not been shown to be better. Now, the post-trial, the prevention of syncope trial, compared metoprolol to placebo in patients with recurrent neurocardiogenic syncope. And there was no difference between metoprolol and placebo. They both had the same effect. Okay, so metoprolol doesn't work. Better than a placebo. Pacemaker doesn't work any better than a placebo. Well, what about a pacemaker compared to metoprolol? Shouldn't they be the same? Because they're both placebo. They don't do anything after all. Well, it's not true. The Precedent trial showed that pacemakers were a way better placebo than was atenolol. So, it depends on what you do. Surgeries are better placebo than a pill is. And talking to a patient is not as good a placebo as actually doing something, even though you're doing nothing, really. Now, Kapchuk is a really interesting guy, and he has done a lot of work on this. And he did this study on irritable bowel syndrome. It was placebo versus placebo versus placebo. And the placebo was a waiting list versus placebo acupuncture. So, not hitting the key point or whatever, just did placebo acupuncture. And they did placebo acupuncture with augmented warmth and attention and confidence by the practitioner. Now, which group would you think did the best? And look at the global improvement in the score, and this is a symptom score, adequate relief in quality of life and symptom severity. And look who did the best. These are all placebos. These are different kinds of placebos, but they make a difference in terms of outcomes of the patient. Now, let's get to some cardiology, and we look at the MIRACLE trial. We all know that CRT can improve heart failure outcomes in many different ways, depending on the patient selection. This is one of the first trials that was done, and they did it with a baseline, with a placebo as part of the study. And what they did was, in half of the patients, they turned the CRT off. They had the CRT implanted, but they turned the CRT off, and they looked at outcome. And it could be regression to the mean, it could be just changes in symptoms. And what they found, if you take a look on the control side, which is the placebo side, there is a difference compared to the CRT side. Yes, indeed, CRT did better than placebo. But what you'll also notice is that those people in the control arm at 6 months had an improvement in the functional class. They did better. Now, that was a placebo effect. There were ways of explaining that in multiple ways. The patient could have expected that they were feeling better. So the other way is that the person who asked the question could have asked the question in a leading way because they knew that there was a device implanted. So the person that asked the question could say, well, maybe you couldn't have walked up 2 flights of stairs, 6 months ago, but can you do it now? Or something like this. So all of a sudden you're leading the patient to thinking, maybe I'm better. Maybe I'm really better. So that's part of it. So there were 2 sides, or actually multiple sides to this placebo effect. Some of it's real. Some of it is imagined, and some of it can come from a variety of different mechanisms. Atrial fibrillation. This is a loaded topic. I will say that I always wanted to do a placebo-controlled atrial fibrillation ablation trial, but I know that would probably they'd throw me out of the profession, and no one would ever do this. But just think about having a definitive trial. We actually put someone to sleep. You put sheaths in the legs. You might even put a catheter in the heart, but then you don't ablate anything, versus ablating something and then looking at the outcome. And you can use any outcome you want. You can use hard outcome of atrial fibrillation. You could use symptomatic atrial fibrillation. What we do know is that people after ablation some have atrial fibrillation, but they're less symptomatic. So the question is, after 5,000 reports, after who knows how much money has been spent on AFib ablation, and I do AFib ablation just about every day, so who's talking here? But the point is, have I really proven, or has anyone really proven beyond a shadow of a doubt that this intervention actually makes a difference? No one has done, there are 5,000 studies and not one study showing that there's improvement versus a real placebo. And that can't mean digoxin. It means some kind of placebo intervention that's the same as the intervention that's being done to purportedly treat the problem. Now, as we think about this, and I've talked to Gust about this when it comes to the SCUDF trial several times, and that is comparing amiodarone to ICD to placebo in the SCUDF trial. You can see that ICDs in heart failure patients show a better survival than placebo and amiodarone. But this was not a placebo defibrillator. This is a placebo pill. What if you put a placebo defibrillator in? Would that have made a difference? We don't know. If it just shifted the curve a little bit, it might be non-significant. It's not a fair comparison. So we don't know what the results would be, but there's never been a placebo-controlled defibrillator trial. What about placebo surgery? Is it ethical? 38% in Iowa said yes. When it came to the residents, 70% of the fellows said yes. So it seems as with more experience that that's the case, and that was the same with the faculty. Well, let's take a look at some placebo surgeries. Internal mammary ligation done to disprove that this was a good procedure. It was done many years ago by 2 groups, Cobb and Diamond. One is a New England Journal paper showing that there was a 70% improvement in symptoms, and actually treadmill tests improved with ST segment changes improved. Now, let me just ask you a question. Has anyone ever done a sham cabbage procedure ever compared? Or what about angioplasty? We got close, but the Courage trial had its problems, but it was not a placebo-controlled trial. No one wants to go there, right? And we have good reason to believe that this therapy works. But my point is, when we think about studies, every time you look at a study, think about the placebo and how it was designed, how the study was designed when you look at the results, because this is really critical to determine the outcomes of studies. Now, the neurosurgeons are a little bit ahead of us. They actually did embryonic dopamine neuron implants in people with Parkinson's disease. They actually drilled holes in people's heads, trephination going back hundreds of years, drilled holes in people's heads and stuck some cells in one group, In the other group, they didn't stick any cells in. They just did plain old trephination. They just drilled holes in their heads. This is a New England Journal paper, and there was an editorial about, is this ethical to do? Both groups did the same. They both improved. Just drilling holes in people's heads, their Parkinsonism got better. And actually, those who were told that they just had that were outraged and disappointed. They still wanted to have the sham surgery, even though there was no benefit shown from implanting these cells. So we need very strong placebos, and I don't know, maybe going back to drilling holes in people's heads is the way to go. What about osteoporotic back surgery? And this created a big problem with the Department of Justice, too. You know, people have back pain, they go for surgery, and they compared vertebroplasty to control. Well, is there any difference? Again, New England Journal paper, no difference. Placebo orthopedic surgery, and just think how much money orthopedic surgeons are making for doing nothing. I mean, I'm not saying they're doing nothing. I'm not saying they're doing nothing. What I'm saying is I'd like to see them prove against a placebo that they're actually doing something. Because we know people feel better after, and people will come to you that have had back surgery, and they will declare beyond a shadow of a doubt that that surgery saved their life, even though it could have been simply a placebo. What about arthroscopy? Just a couple of years ago. Arthroscopy for meniscal tears. Sham surgery, I think this is done in Finland, compared to arthroscopic meniscectomy. No difference. No difference compared to placebo. It's the same as placebo. Now, here's an interesting study, and this goes to compliance. This goes back many years. And I talked about women and placebo, but men also have an issue with placebo. This is an interesting study. This is all men. There's 5,000 men. It's a big study, and it was before we had statins. And people were treating patients to reduce cholesterol to improve outcomes, thinking that cholesterol was, a big issue. So they gave clofibrate. And if you took your clofibrate at a compliance level of 80%, your mortality in 5 years was 15%. And if you didn't, it was 24%, and the significance was quite high. This is not particularly great, interesting news, right? I mean, if you lower your cholesterol, you're going to do better. Well, but that wasn't the point of this New England Journal paper. The point of this New England Journal paper was the placebo. If you took your placebo at an 80% level, you did the same as if you took your clofibrate. If you didn't take your placebo, it was a 28% mortality, and the p-value was 10 to the minus 16th. This is the most, if you want to talk about the most significant study in the literature, this is it. You're not going to find a significance greater than 10 to the minus 16th. Placebo. Take your placebo. Make sure you take your placebo. And what they said at the end of the study was, these data demonstrate with the great difficulty, if not impossibility, of drawing any valid conclusions from findings about mortality and morbidity. And to this day, we have not found exactly what's going on with compliance effects. But this is not the only study. You know about beta blockers and mortality. Well, the BHAT trial showed, indeed, if you take a beta blocker, you do better than if you take a placebo. But take a look at compliance. The same thing. If you're compliant with your placebo, you do much better than if you're non-compliant with your placebo. And people have looked at different, reasons, smoking, divorce, alcohol, different other issues, comorbidities. They couldn't find a specific issue other than compliance that is related to the outcome. So it's true when it comes to cholesterol, it's true when it comes to beta blockers, and it's also true when it comes to heart failure. And that comes from data on amiodarone versus placebo, and showing that people that were compliant with this is Stephen Singh's study, I think it's CHF stat, showing that that if you take your placebo versus not taking your placebo, you do about 3 times better in terms of your outcome. So placebo can affect pain, functionality, quality of life, syncope, heart failure, atrial fibrillation, and survival. Not bad for a drug that absolutely does nothing at all. We can make a big dent without even having to create necessarily an adverse effect. So these are powerful effects. So what's going on here? Well, part of this is what I would call a Wizard of Oz effect. It's because we believe that it's going to work, that it works. And we don't know that placebo and nocebo couldn't exist in the same person. Someone could actually feel better with one thing, but worse with another. And it could work in different ways. There are those who would say that placebo actually is powerless, and there are some studies that have shown that, either in terms of smoking, depression, and in nausea. Where there were placebo-controlled trials comparing placebo to no therapy. But there are problems here. There are problems with all these trials, because it's not the placebo that's the important thing. It's the placebo effect. And that involves attention, it involves interaction, it It involves the doctor and nurse relationship to the patient. It involves things that are generally unmeasurable. And you have to be able to do a very good controlled trial, which has not been done in these cases. So I think this information, when it says no justification to use placebo, is I don't think anyone would believe this kind of information. And there's been quite a bit that discounts this particular thing. But I wanted to mention that in any event, because there are those who believe that placebo has absolutely no effect at all. Now, Kapchuk did another study that I think is important. Because one thing is, when you deceive a patient, and this is considered unethical, by giving them a placebo, that's a bad thing to do. So he decided to do another thing. For irritable bowel syndrome, he said, I'm going to give you a placebo. This is just a sugar pill. And I'm going to tell you, I'm giving it to you. And then we'll see how you feel. And what it turned out was that placebos administered without deception may be an effective treatment for irritable bowel. He actually told them he was giving them a placebo, and they still felt better. So, further research is warranted. That's the way you always enter, most manuscripts. Well, yes, but I think the issue here is they got attention. Someone listened to their symptoms and their complaints, and they felt better, because part of the issue with irritable bowel probably relates to whatever neurocognitive pathways that are involved in what's going on in your gut. I mean, it's probably tightly linked with the autonomic nervous system. And this just basically shows those results. Open placebo, looking at global improvement, symptom severity, adequate relief, and quality of life. Quite a bit different, highly significant. If this was a drug, if you were going to go to the FDA and go with this drug that is a sugar pill, where you're telling the patient, I'm giving you this sugar pill and you're going to feel better, this is fantastic medicine, fantastic. So what can explain placebo? Well, there could be psychological factors, the natural course of the disease, and a variety of other things. Part of the mechanism can be the following, and I just want to give you a couple of ideas, but this is actually quite a complicated issue. Regression to the mean, certainly a possibility. The patient's symptoms vary over time, and they just tend to go, sometimes they're bad, sometimes they're good. They come to see you when they're bad, and they go away by themselves. Conditioning response, we'll talk about that. Expectation is important. Endorphin release, neurocognitive pathways, the meaning response, and I think this is culturally, ethically, gender, and genetically related. Now, in an animal model, this is an interesting thing, because the same thing has happened in humans. They've done the same kind of experiments. But if you give rats saccharin-flavored water with cyclophosphamide, they become immunosuppressed. And then you wait a while, and the immunosuppression goes away. And then 10 days later, you give half saccharin, just saccharin, in a rat. The saccharin lowered antibody titers. The animals had a placebo effect to saccharin. They knew what was going to happen. It's what happens with Pavlov's dogs. A bell rings and they salivate. I mean, it's just a bell. It's a placebo, right? But they still salivated. So there's something physiologically going on by what is getting processed in the brain. And some of this has been worked out. I don't know how good this actually is. I mean, this is the hypothesis is that it involves the amygdala, and it involves dopaminergic pathways and the insular cortex. And some of this presumably may or may not be the case. But this has been looked into as to what might be some of the mechanisms going on here. And it turns out that this specific pathway may be genetically related, and that there may be genes in humans that control for this serotonergic modulation of this amygdala activity, and actually anxiety relief. And you can almost make sense of why that may be the case. There may be something to the placebo effect that draws communities together and has leaders in the community that tells the people what to do, and they feel better because they like to be led by a leader. And the leaders tend to be the healthcare profession now. I mean, we come from a background of leaders. I mean, doctors and nurses were, they've always been held highly in society. We have high respect. Now, as we become healthcare providers, we lose our respect, and I think what's going to happen is patients are going to get less benefit, and they're going to be looking for it. So they're going to be looking for this placebo that they have not been able to find, because they're looking for leaders in a society. And that's probably true in politics, too. It's probably what's happening in politics right now. Someone is looking for a true leader that's going to take us out of the problem we have, whatever problems that may be. And so I think it makes sense that there's a genetic background to this, and the people that have this genetic background actually are probably going to more likely survive, because communities survive much better than individuals by themselves. But the nocebo mechanisms may be different. This appears to be a cholecystokinin mechanism, so pain mechanism. And this mechanism could imply that you could have a placebo effect and a nocebo effect, both with the same medication. You could get a benefit and an adverse effect from the same medication. So there's, in terms of the reward mechanism, you might involve the amygdala, you might involve the nucleus accumbens. It may or may not be the case. I don't know, how good the science is here, but it may involve different pathways, more of a reward mechanism. And oxytocin is another modulator which also makes sense as you think about it. So, there's been some work on addiction and reward circuits and, the opioid mu receptor. And then some of the work on brain PET scanning has looked at a dopamine release in Parkinson's disease. And Parkinson's disease, like congestive heart failure, are two specific conditions and syncope in which placebo works very well. So there have been some attempts to map out what this placebo effect may be. And again, I'm no expert in this. I don't know what the truth of the matter is when it comes to PET scanning and the mu opioid receptor. But nevertheless, it turns out that apparently anticipation and saline injection can activate certain parts of the brain, which makes some sense to me, even if it's not necessarily true. I don't really know the data. And this is also a rather soft piece of information, but I thought I'd show it anyway, and it's quantitative EEG recordings that's supposedly mapping the placebo effect in depressed patients, where they gave them an antidepressant or a placebo. And they found that those that were given an antidepressant, some of them got better and some of them didn't. And some of them got better with the placebo, or some of them didn't. But different parts of the brain seem to activate. So it's conceivable, when you give a pill that has a benefit, you might get the physiological benefit, and you might get the psychological benefit. But you could get the physiological benefit from a pill and a psychological harm, so you can get a nocebo effect with a physiological benefit and vice versa. So it can actually be a very complicated issue about how these two things are interacting. There are also expectation effects. One is that explicit expectation about an outcome may change the outcome. Here's an example. And we all know this. We practice medicine this way. We learned what to do to take care of patients. You see a patient, you say, I'm going to give you this medicine. I know this is the right medicine for you. This is going to work. You're going to feel better. I'll see you in a couple of weeks. That's a Jastrow effect. It might not work, but it has a better chance of working than to tell a patient, I'm going to give you this medicine, and you're likely going to die from it. Chances are it's not going to work all that well. There's also the Hawthorne effect. And this is an interesting effect. Let's see if I got some slides on this. So the Hawthorne effect, it was first done in a factory where they actually looked at lighting levels, and they told the people who were working in the factory, we're going to see how productive you're going to be. And so we're going to change the lighting level to see which is the best way to go for your activity. And what they found was productivity increased even when they could hardly see what they were doing. I mean, they were turning down the lights so you could basically almost blind, and their productivity went up. And what they found was that simply observing a worker, they got better. They got better. So basically, if you see a patient and you say, I'm not sure this medicine is going to work. I think it's going to work, but I want to see you back in a week and want to see if you're improving. So you set up another follow-up visit. Now, you're forgetting about whether you get reimbursed for it. It's still probably worth it, because they're going to come back and say, Doc, thanks for that medicine. That was great. I feel much better. Or if they want more attention, they're going to say, no, I think I'm only a little bit better. I need something else. But this is the Hawthorne effect. Observing the patient, they might get better simply by observing the patient. Let's see here. Okay, the John Henry effect. This is where you give someone a placebo and the patient thinks they're going to get a benefit, and so they try to get the benefit. They read about the medicine, this medicine is probably, and they see the commercial on television, and besides all the stuff about that they're going to die from this medicine, they might occasionally put in a word that it might have a benefit for their diabetes or something like that. So, they're looking to get that effect. The Pygmalian effect, that's very much the same kind of thing, and that is, if you believe you're going to get that effect, you will see it. And this goes back to the mythology of Pygmalion, who was a prince of Cyprus, who sculpted a statue. He fell in love with the statue, and he prayed to Aphrodite to bring her to life, and she comes to life. So his belief made the thing come true. So if you have an enthusiastic doctor, and this has been tested, the outcome will be better than an unenthusiastic doctor, someone who doesn't look you in the face, that's constantly filling out the electronic medical record, who could care less if you actually were stepping in the office and just couldn't wait for you to leave because you're wasting his time or her time. You'd would much rather be doing something else or just want to get the patient out of there as soon as possible. So the enthusiastic doctor who cares about the patient, who is interested in the outcome, who is interested in the therapy, is going to get a better effect. It's a no-brainer, right? And but this is a placebo effect. Experimenter effects. So in your office, you have patients that are sitting around waiting. You don't know what's happening there. And you have some nurses there and you have some secretaries there that are taking care of the patient. You call the patient in, but the patient meanwhile is sitting there with other patients and they're talking. And so they've done this where they put stooges in the waiting room, and they said, who are you seeing? Oh, you're seeing Dr. Olshansky? Well, I hear he's not such a good doctor. Dr. Olshansky, well, he's world famous. Do you think there's a difference? It's a placebo effect, but it's a big effect. And so you can design your office and your practice to get that benefit. Or if you don't want that benefit, you don't want your patients to come and see you, do something else. Now, trial participation. It's been shown that people that participate in trials, there's a trial effect. Again, like a Hawthorne effect, if the people that go into trials are healthier, they do better, and they don't necessarily give you what happens in real life. So there are some issues here. Let me see here, because I'm running out of time. But halo effect. So a brand new treatment. Well, I got this new catheter. It basically tells us exactly what kind of force we're putting on the catheter tip. We know we're going to get a good lesion. It's going to get a better result. So the treatment is going to be better with this halo effect. Now, I exercise every day. In fact, I got a, what do you call it? One of these things on, Fitbit. But, it's placebo, right? I know it's placebo. I worked out this morning. I thought I was going to lose some weight, maybe get a little bit more healthy. So what they did was a study. They did a study. They took women who worked in hotels, and they told half of them, the kind of work you're doing is actually what the American Heart Association sanctions as healthy for you. And the other group, they told them nothing. They gave them activity monitors, and they had them walk around, and they checked their blood pressure, weight, and body fat. And they found that those people that they told the good news lost weight, had lower blood pressure, and were overall better. But they looked at their activity. There was no difference. Same activity, but they did better. Don't know why, but they were told they were going to do better, and they did better. So there's also this meaning response. And this has been disproven in many therapies, like transmyocardial revascularization for one. But this is where you have a plausible, understandable mechanism by which something can happen. You got this blocked artery. We're going to fix it. We're going to fix that pipe. It's plugged up. We're going to put a new artery in there, and you're going to be all better all of a sudden. The meaning response, it makes sense. But some of this has been tested, like transmyocardial revascularization, and it showed no benefit necessarily over the placebo response if the placebo is well designed. What about a value effect? I mentioned this before. If the costs are very high, then you can get a value. And this was tested with pain. They gave people electric shocks, and they gave them either expensive placebo or cheap placebo. And they found those who received the higher price placebo had lower pain with the shocks. Now, one other question I asked the people at the University of Iowa is, rank in order of importance concerning your role as a doctor. Latest technology, delivery of health care, employment of evidence-based guidelines, preventing disease before it occurs, establishing solid patient relationships. 1 was the highest score, 5 was the lowest score, and people all thought that establishing solid patient relationships is important. So this, I think, is a critical issue because if we don't do that and we decide to go with guidelines only and we're all one big gray mass of healthcare providers, people will go elsewhere. They'll find something else. Who needs the doctor if that doctor is not taking care of your particular problems? So the implications here are that placebo and nocebo are common in medical practice. They involve relationship to our patient, and that the doctor, nurse, and healthcare provider, as we are now called, are the most valuable resources for healing patients. And I think that when we think about medicine and our core values, that medicine is really about people, and the reward is in the care we give, and our relationship to patients are the key. So with that, I'll stop, and I thank you very much for listening. I'd be happy if I could answer any questions. Thanks.
Dr. Olshansky, thank you for that very thought-provoking talk and very interested in the audience response.
So that was great. That was very provocative. I kept thinking about my own experience with AFib ablation. And I don't know, over the past 15 years, I think I got much better outcomes in terms of patient satisfaction. I don't think I'm much better technically. Maybe I get faster, maybe I get safer, more reliable, but we're doing the same thing with the same limitations we had back 15 years ago. So am I a better deliverer of the placebo effect
Yes.
when it comes? Am I delivering placebo to myself as an operator, judging my own outcomes?
That's interesting. Yeah, I think you probably are. I mean, part of the reason we stay in the profession is because we enjoy doing it, you know, and we get the placebo benefit. Yeah.
And the other thing is, I have patients that say have AFib, they have an ablation, and they will come back and they have a positive response. But they keep telling me, you know, every now and then I feel like I'm going to go into AFib, and then it just goes back. So I keep nurturing a placebo effect long term. I tell them, well, it's because the ablation worked, and it's as if your heart wants to go back to AFib, but because of the ablation, you just get a few extra beats and then it settles. I think instilling confidence back, it's like I have to renew a placebo effect on that patient. It may be real, it may be that what I'm saying is true, but I don't know that. So is the placebo effect something that you have to keep nurturing and keeping alive?
I think so. And the other thing about it that's I think unrealized, especially, you know, as electrophysiologists, you know, there are different levels of different providers, and when you're the subspecialty person, the person that's coming to you has all kinds of expectations. They've been preloaded by all kinds of people that the real answer is going to come from you. So you know, and the buck stops there, and that becomes important. And that, I think, in anyone's profession, whatever they're doing, you want that to be instilled in part of that profession, that the patient has total belief in you. That they trust you completely, and that your information is really valuable and valid information. When it comes to electrophysiologists, we're in a very tough position. I think this is where placebo becomes so critical, because we have to use it in terms of a lot of the things. Because people send patients to us, you know, with palpitations, dizziness, lightheadedness, syncope, things that, you know, require some placebo intervention, and even symptoms like atrial fibrillation. So we have to be very cognizant, but all of us have to be cognizant about this issue.
Thank you for that very thought-provoking talk. I have two questions. One is more scientific. I've never had a placebo pill, but I'm guessing saccharin tastes a little sweeter. So have people done studies on sweet pills versus nasty-tasting pills versus no-taste pills?
Yeah, and this is a big problem, because you have to have the pill taste like the drug, because the patient will find it out. And this has become a problem with, for example, fish oil placebo pills. Because how are you going to make a pill that tastes like fish oil? And, you know, corn oil doesn't taste like it. You know, mineral oil doesn't taste like it. So how are you going to, you know, I mean, how are you going to do this? It becomes very difficult. In terms of the taste by itself, I don't know. I actually don't know. But I would think it would make a difference. Very much like the color would make a difference. I would think it has to.
My other question is, it's more of a controversial statement I'm going to make, but on one side, with this whole concept of patient satisfaction, the metrics, and you know, there are studies which showed satisfied patients might actually do worse because you're giving what they want. You know, it's almost like we're in a world of being sham artists for you to do what's needed, whether it's physiological or non-physiological. I don't know what your thoughts are on. And I mean, it's a very interesting concept in the context of placebo having a physiological change and impact, but it also begs the question, do we need to do physicians who can do a sham better than physicians who can do a sham better? Will they shine more?
Well, I mean, I think this is a fine line. I mean, I think it's a very difficult topic, because I think there's a lot of sham. You know, whether it's alternative medicine, people doing weird things. I mean, I've heard of people doing angioplasties for the veins in the neck for POTS. You know, coming up with things like this, which are like crazy. But you know, and maybe, who knows? Maybe they're real. But I think it's crazy. But you know, there's a difference between that and not being a sham artist, but saying, you know, your problem is actually really complicated. I don't know what the right answer is. We're going to use the best science we have. But a lot of things really, there are a lot of unknowns, and you might not respond like everybody else, but I think this is the right thing for you to do. So kind of being honest, but, you know, but not knowing the right answer, but yet being definitive enough that the patient realizes you're doing the best that you can for them, but at the same time you're using the best science and you're instilling, you know, an empathetic view. And I think that's a complicated, it's an art, but that's really what medicine is, and that's what puts us in our position. It's not that we know the results of the studies, because you can find, I mean, I've talked to, when I was, you know, I was in this case working with a group against, where the Department of Justice was you know, looking at ICD implants, and I was, you know, defending, you know, certain practices, which is, you know, about gray zone issues. I can tell you that if you happen to be working at the department, if you happen to be Amy Easton working at the Department of Justice as a lawyer, she knows more about all the studies on defibrillators than anyone in this room, and can argue every little detail about that. But could she take care of a patient? I doubt it, because she can't understand what that's all about. When you talk to a person who works for a drug company and they say, why don't you give my drug? And they don't understand what it means when you're actually sitting with the patient and the family in front of you and you're talking to the patient. We understand that because that's what we do every single day. It doesn't happen all of a sudden. We don't learn this in a matter of a day or two. It takes years to develop this. I'd say it's an art. It's not a placebo. You can call it placebo if you want, but it's what our profession really is. And it's a real thing. And it isn't sham. I mean, I don't think anyone will ever it elevates our position because no one can understand this, because unless you live it every day, you cannot be it. You can't just look at the science and say, I know what you should be doing. So it's a complicated, and I hope I answered your question, but it's a complicated issue.
Yeah, I'd like to posit an alternative explanation to this sham effect. If you have a placebo group and a treatment group and they're doing about the same, we're assuming the placebo group went up, but maybe the treatment group thought, hey, I'm probably getting placebo, and had adverse effect on them. Wouldn't it be better to add an open label third arm to that, where the prescriber and the individual knows what they're getting and see what their outcome is compared to the treatment of placebo group?
That's a fantastic point, and it actually complicates study design tremendously, because we're assuming that the drug effect and that the expectation effect are only going to be positive, and we don't know that it couldn't go the other way. We don't know that both of them could. We don't know that the placebo is a real placebo even. Giving a sugar pill, maybe that actually increases blood sugar or something like that. How do we know what's a real placebo? So we have to get something that matches perfectly and doesn't have the other effects. So designing a trial is important that way, and I think having that extra arm like that makes sense. And then when you look at registry data, sometimes it's not consistent with the results of trials. But there's another issue as well. And I think part of the problem is we need to do triple and quadruple blind studies, not just double blind. Because a double blind study means that the patient and the doctor doesn't know what's going on. But the doctor already has an assumption that you're treating a specific problem. If I'm an electrophysiologist and I'm implanting a defibrillator, they already have an expectation. Who should be following the results of the study? Or an atrial fibrillation ablation study? Should it be an electrophysiologist? That electrophysiologist is already pre-programmed to look for benefit. You should pick someone off the street. Maybe a gynecologist should be looking at the data, because they know nothing about what those results should be. They should know nothing about what those results could be, because that's the only way you'll know. You have to have a completely blinded study to know if the results are going to be beneficial or not. And I bet if we did that, we'd find completely different results than we see in clinical, in the studies we have now.
The placebo effect, as you pointed out, I think is universal. Just think of what FDR did as opposed to Hoover in the Depression with his one talk and his fireside chats. It's been said in retrospect that in 1939, before this country ginned itself up to fight the war, the unemployment rate was almost exactly the same. It was 19% versus 25% in the middle of the Depression in 34, 35, yet everybody felt better. And in retrospect, many of the things that Roosevelt did really were placebo effects. They didn't really accomplish anything. So I think there's some mystery to human relations, and when people go to see physicians, they really go to see priests.
And in some religions, they're the same.
And they're the same.
They are the same.
Yes.
And in some professions, you have a choice. You can either be, a person of God, or you can be a doctor. I mean, that's
yes.
basically that's where.
Yes. Yeah.
And about the politics, can you imagine what this country would be like if we were all unified against with one leader who we all agreed that was going to lead us in the right direction?
Of course.
I mean, the placebo effect of that is so powerful, where people, and this is where I think that there may be a genetic issue related here, because this is where there's a benefit that you get in your brain from this link, this connection that I think that's critical. And we do this on a patient by patient, on a day by day basis. This is what our profession's about.
Yeah. Practicing medicine is not building cars.
That's correct.
On that note, Thank you, my friend.
Good. Thank you very much.